Welcome to Health Frontiers, where we explore the uncharted territories of well-being. I am Dr. Robert Lahita, also known as Dr. Bob. With over 50 years in rheumatology and immunology and 17 years as the chair of medicine at 3 major medical centers, my mission is to simplify complex medical issues for you. Join me as we uncover the latest breakthroughs in health, answer your pressing questions, and discuss nutrition and holistic living. This podcast is all about empowering you with the knowledge and tools to manage your health effectively. Let's embark on this transformative journey together. Hi, I'm Dr. Bob, and this is Health Frontiers with Dr. Bob, and I'm welcoming you to this show, which is particularly timely. And as you will hear us going forward, I have a special guest today because of the marathon that's coming in New York City, but also because of long-distance running around the country and the various marathons that happen. Before I do that, I want to just say that people have been writing in, and we have an email which is called askdrbob@healthfrontierspod.com. You'll see this again at the end of the program. So in my monologue today, I've answered a few questions for people asking about osteoarthritis and rheumatoid arthritis and what are the differences between the two conditions. The first question is, my husband is a plumber and he constantly has pains in his hands. What could this be? Well, pain in the hands can have many causes, but the major issue is most likely to be osteoarthritis, which all of us may get at some point as we age. That's called degenerative joint disease. It's very common among people who use their hands all of the time, and it happens to run in families. It can affect various joints in your body, particularly your hands, your feet, and even your spine. The doctor makes this diagnosis by getting plain x-rays of your joints, and he looks for particular changes. So the other question is, what does this look like, and how is it different from rheumatoid arthritis? Well, it's easy for most doctors to discern the two. The radiologist or the x-ray specialist generally gives a report to the doctor that says the patient has osteoarthritis of the joints. Simple. But not really. The typical overhanging bone with enlargement of the end of the fingers and swelling of the knuckles with pain is often the only symptom that people experience. And generally, and this is important, that the pain mostly occurs at the end of the day versus the beginning of the day. When the pain is prominent at the beginning of the day, it is usually rheumatoid arthritis. When it's prevalent at the end of the day, after a full day's work, for example, that is usually osteoarthritis. Not everyone with osteoarthritis has pain, and when it occurs, it can be pretty nasty, especially if you use the afflicted joints in your work in a daily manner. So there's proliferation of bone in the joints, and we call these things osteophytes. In rheumatoid arthritis, on the other hand, the joints are eroded, and we call those erosions, and the erosions occur in the actual bone next to the joint. That's a term called periarticular osteopenia and periarticular erosions. That's different than osteoarthritis. So I already said that osteoarthritis can be all over the body, not just the hands. And what's a quick way that the family doctor, this patient writes, can make the difference between the two conditions? And in OA, as I mentioned, pain is mostly at night. In RA, it's mostly in the morning. Now, rheumatoid arthritis is also something we call a symmetrical joint disease. That means if one of the knees is involved, the other knee is usually involved. Well, in osteoarthritis, particularly those people who have extra weight, are overweight, or really morbidly obese, both knees can be affected with osteoarthritis. Whereas rheumatoid arthritis does not just occur in one joint like the wrist or in one elbow or one shoulder. It's usually symmetrical. It's in both joints at the time that you have the pain, and it's worse in the morning hours. So one of our questions is, are you stiff in the morning when you wake up? Does it feel like when you get out of bed, you're standing on stones or cut glass? If that's the case, the doctor usually has a suspicion that this could be rheumatoid arthritis and not osteoarthritis. And they're different. Why are they different? Well, everybody asks that question. They're different because osteoarthritis is degenerative arthritis and does not generally involve the immune system. Rheumatoid arthritis is the most common autoimmune disease. And we'll talk about autoimmune diseases in a future show. But right now, for all sakes and purposes, autoimmune disease in rheumatoid arthritis means that the body its immune system makes antibodies against various cells and tissues. That's not the case for everybody, but for the most part, there are positive tests that your doctor or your rheumatologist can get to prove that you have rheumatoid arthritis. Now, another question is, can both of these diseases occur in the same patient? And the answer is absolutely. We call those overlapping arthritides. And you can have osteoarthritis as you get older and then develop rheumatoid arthritis or vice versa. Most people don't understand that rheumatoid arthritis can occur suddenly in somebody who's 35 to 40 years old. In fact, that's the usual time in age where rheumatoid arthritis sets in, whereas osteoarthritis is more common after the age of, say, 50 or 55. Which arthritis is worse, this patient writes? Osteoarthritis or rheumatoid arthritis? And as I mentioned, rheumatoid arthritis has more what we call comorbidities. And that means that what usually takes people with rheumatoid arthritis down and makes them very sick is the heart disease, the vascular disease, the diseases that are aside from the joint and muscle involvement of that disease. So that's why it's so important to be treated and treated early with rheumatoid arthritis. Osteoarthritis, not necessarily so. That's degenerative. So you've heard that there can be bone on bone in some people's knees, and the doctor can examine your knee. He can examine other things like your elbow or your shoulder and find something called crepitus when the joint moves. And that's sort of a crackling sound that occurs in the joint itself. And that is usually degeneration, and it's bone on bone. So the cartilage disappears. And as you'll hear with our guest today, that there can be injections of the joints with substances that will make those joints better, in osteoarthritis particularly. We also give injections to patients with rheumatoid arthritis, but not as common as those with osteoarthritis. Now, the next question I have here is from a lady who says, my nephew has severe joint pain and he's only 12 years of age. Can children get arthritis? And the answer is absolutely. Children can get inflammatory joint diseases, and there are pediatric rheumatologists who take care of such children. The Arthritis Foundation has a whole program for children. So if you're concerned about this, your neighborhood, your area, your county probably has an Arthritis Foundation chapter that you can go to, and they will be glad to send you information on childhood arthritides. So we call that juvenile inflammatory arthritis, which is known as JIA. Now, there are many different forms of arthritis that affect children. They're not all the same. But the pediatric rheumatologists can categorize and treat children as effectively as they can to prevent stunted growth, for example, extraordinarily swollen joints that never feel comfortable, and it affects the child's learning ability. It affects him or her in school, and it actually affects their overall quality of life. So this is something that if you have joint pain in your child, don't say this is just growing pain. Make sure your doctor evaluates your child and sees exactly what's there. And the child can be as young as 5 years of age and as old as 17 or 18 years of age. After 18, we consider that an adult with arthritis. Now, we have many, many ways to treat these various conditions. Osteoarthritis is probably more difficult to treat than rheumatoid arthritis. You thought I was going to say the reverse, right? But osteoarthritis is degenerative, and we can treat it with injection of the joints. We can give you other medications to thwart the proliferation of bone at the joint. But that is how osteoarthritis is treated, with local injections and with other medications that can be introduced to your body. It's not as easy to treat osteo as it is rheumatoid arthritis. Now, you see these drugs for rheumatoid arthritis on television all the time. And I won't mention some of the products, but I can say that this area is probably the most active area for drug development in the world. And this is that there are so many things we call DMARDs, or disease-modifying drugs, and there are drugs called biologicals, which are also disease-modifying. Now, admittedly, some of these drugs are very expensive, and I'm sure you've heard that from your family physician, and you've probably even heard that from your rheumatologist if you get to a specialist. But your insurance company will approve the drug if the doctor intervenes, if the drug particularly is turned down, that is disallowed by your insurance policy. But if you need it, you will get it. And I am assured by pharma that they will allow you to get the drug if it's absolutely needed. And at some point, we'll talk about the other forms of arthritis. A last question, perhaps two last questions here. This comes from a gentleman. My cousin Charlie gets injections in his osteoarthritic joints. How does that help? As I mentioned, if you have a hot red joint, I don't think that should be injected. A hot red single joint, the doctor might want to put a needle in it and do what's called an aspiration to see if there's an infection. Now, if there's an infection, that joint has to be treated as an emergency. And that's what happens in the emergency room or the Urgy Center. They'll put a needle in a swollen red joint to see if pus can be removed from there. It can be cultured to find out what organism is there. And the doctor doesn't want to put cortisone into an infected joint because that'll just make it worse. So the doctor must be always cautious about an infected joint. Your cousin might also get injections of a substance called hyaluronic acid to his knee, in order to see whether that substance or hyaluronic acid, which is a gel, can be put into the joint to act as a cushion. It's a substance that is very popular with orthopedic surgeons and many rheumatologists and podiatrists, as you will find out shortly. This is a lubricant, basically, for the joint, and it's sometimes very, very helpful. But our guest this morning is going to tell you about many other agents that can be given to you. Last question right now, so we can go on to our guest. My grandmother, this is from a lady, cannot walk long distances because of pains in her legs. Now, this is really critical because at a certain age, certain people, either genetically or not genetically, develop things called spinal stenosis. And spinal stenosis is often the result of osteoarthritis. Now, what is spinal stenosis? Well, the word stenosis means narrowing, and spinal stenosis means that the bone encroaches on the spinal cord in the lower back, and you get, as you walk, distinct pains in your calves and maybe pains in your whole leg, so that the patient with spinal stenosis can only walk a few feet, has to sit down and rest, and the pains go away. And then he or she will get up and walk another few yards, and the pain will reoccur. Now, with spinal stenosis, the gradual squeezing of the spinal cord results in the pain, as I mentioned, when walking or exercising. There feels like there's no circulation in your legs. So when you sit down and the pain goes away, the circulation feels like it's come back. But the patient needs to see an orthopedic surgeon for possible spine surgery, which today in 2024 is a very easy procedure to finalize. So I think I'm going to end the questions from our guests. Now, I invite all of you who are watching in healthfrontierspod.com. That's our website, by the way, and it'll be on the screen shortly. I invite all of you to write in and ask your questions, and some of your questions will be answered on this show. Now, remember, as I said in the beginning or at the trailer, this is not a personal medical consultation. We don't bill for this, and we can't give you, an individual, a diagnosis. But we can help you to understand the disease process and suggest that you see a specialist like your family doctor or your rheumatologist or your orthopedic surgeon to resolve your problems. So now I'm going to invite our guests in for today. So I'm very happy to have with us today Dr. Barry Jansen. Dr. Jansen is a board-certified podiatrist who is an expert in foot and ankle injuries, but also, in general, will give us extremely good advice for long-distance running, particularly if you're running the marathon or even a 5K race. We often have questions which are very, very pertinent and very, very timely. So welcome, Dr. Jansen. It's good to have you here.
Dr. Bob. It's a pleasure being on Frontier with you. I am very happy to be here.
Thank you. So our first question is, how do you prepare your feet for a long run like the marathon?
Well, Bob, I guess the best description of feet is like anywhere else in your body. It's the skin, okay, the largest organ on our body, the skin.
Right.
And what we want to do is, especially like 3-4 weeks out, I would say you want to condition your feet a little bit. First thing is let's get some moisture in it, hydration. They have these special creams that actually are anti-friction creams, lubricants almost. On the other hand, we want to toughen the feet on the bottom because let's face it, we're going to be pounding for long, long distances.
26.2
miles. That's a long way. So we really want to make sure that they're tough enough. So they do have sprays and various things. And you got to be careful with the sprays because they're toughening up the bottom. You don't want to dry out the top.
Right.
So you might have to do both almost, one in the morning, one in the evening. Okay?
Yeah, so people train for the marathon.
Yes.
I had run a marathon years ago, 1984. So you can imagine how long ago that was. But nevertheless, I trained by running upwards of 22 miles a day.
Yeah.
Now, they should know to take care of their skin during their training. Is that
right? Critical, and that's one of those things that's overlooked a lot. People don't think about their skin. I just put on a sneaker and I'm off and running, and I'm just going to have the endurance. Then they get blisters. They have all kinds of other problems, blisters between their toes.
Right.
So I always say to people, think about your skin. It's real important. That's going to have to go the distance.
Yes.
So you really want to moisturize it and you want to toughen it up. One little trick that some of these marathoners will actually use, they use lemon on the bottom of their feet, which actually is like an astringent, and it actually toughens up the skin.
Wow.
Yeah.
I've never heard that. That's fantastic.
Yeah.
And I hope all of you runners are listening to this. So what about socks?
Okay, let's go to the socks. It's a funny thing because what is everybody always thinking about? They always think cotton. I should wear natural fibers, cotton.
Yes.
That is the worst thing you could possibly be wearing on your feet when you're running. Because you got to remember, the reason that we survived in our evolution is because we perspire.
Yes.
Okay? And it allows us to go long distance, and we don't have to stop because we keep perspiring. It cools us off, right? All right, so if your feet are soggy with a cotton sock on it and you go a long distance, you're going to have all kinds of problems. So they have these new synthetic fibers. They have, polyester, nylon, all these various kinds of socks. And what are they designed to do? Wick away the moisture. By wicking it away from your foot, it evaporates.
Yes.
And basically it keeps your foot dry and comfortable.
Yes.
Also with socks, they want to make them so they're not too bulky. You don't want a gigantically thick sock and you're putting your foot in this because you're moving.
Yes.
It has to be pretty tight to your foot. A lot of times it's nice when they have a little elastic around the arch. It gives you a little extra support.
Yes.
And people love those kind of socks. Matter of fact, there's so many different kinds of socks. I'm going to mention a few.
Well, I remember while you're doing that, running and having my toes by the end of the marathon very bloodied because my socks were so wet.
Yes.
And not only that, because of the sprinklers during the race.
Yes.
And people offering cups of water at the 10th mile, the 15th mile.
Right.
And the water gets into your sneaker
Sneakers.
and your feet are basically red
And so
raw.
many times, of course, the weather, it rained, there's puddles all over the place. You're running through these puddles, your feet are getting wet, right?
Yes, right.
So these companies have made these, and it's probably 1,000 more. But the more popular one's called Balega. Saucony makes one, Swiftwick, Right Sock, Bombas. Everybody's thought Bombas on TV. They give one pair if you get one. All of these are really good. And I always say they have to have a deep heel cup because you want this sock to stay in place. That's a second problem. If you have movement, if anything, and the sock is riding down and crinkles up or something, you're going to get a blister. I mean, that's right where you're going to get a blister. So socks are incredibly important.
Yes, and I think blisters, as those of you who are running many marathons and many 10K races, blisters often impede your ability to train for these races. And so I think Dr. Jansen's advice should be taken very, very seriously because it means the world of difference. It's not just the pasta dinner the night before, but prepping with the proper socks. Now, what about sneakers?
Okay, so let's go to sneakers. I mean, I hate to say this, but I tell everyone the best sneaker anyone could probably wear is a running sneaker. Why? Running sneakers, lightweight. They're cushioned better than a regular sneaker. Why? Because you're running, right?
Right.
They are built better, so they last longer. So I always say to people, if you want to have a sneaker on all day, even if you're taking a walk, if you're going on a trip and you want to walk around, there's nothing can beat a running sneaker. Now, of course, there's different insoles that go into these running sneakers and everything else, and all of those are very, very important. Again, many, many kinds of brands. And the real runners know the better brands. You know, you have, let me just go over these for you, so because I hate, you have Asics. Their best one is called a Nova Blast. New Balance, it's called a Fuel Cell Rebel. Nike, Pegasus, Brooks, Ghost, Adidas, Supernova Rise. These are all, and you have Hoka's and so many other kinds of sneakers. All excellent, well-built, and they're really designed to take the punishment. Now, let's go to whether you should be having one pair, two pairs, three pairs.
That's a good question.
You need to rotate your sneakers. You got to remember, the insole and everything compresses when you're running. So you got to give it, a day off or 2 days off so it's able to get back to where it was. Second, moisture does wick out of your sock. Where do you think it's going? It's going into the sneaker. So you want to really make sure they're very, very dry. Okay, so now there's a question that people have of whether you should run barefoot.
Yes, that was one of my questions.
I cannot think of one good reason to run barefoot. If you don't have something wicking away the moisture off that foot and you're slishing and sloshing in that sneaker, you're going to have problems, especially in a long run like a marathon.
Yes, that's very, very true. And I did have as a question because there are a couple of runners that I know who run without socks, and they think that's more natural. And, of course, the African marathoners run barefoot in training in their countries, which I find incredible. But
Unbelievable.
the bottom of their feet apparently are hard like leather.
I think that's why. I think they've done it for so long. Let's face it, the body's a resilient machine, and it'll make callousing and whatever, so you probably can do that.
That's
you probably
extraordinary.
Could. Yeah.
Well, those are good pointers for long-distance running. The other thing is we have, being a medical show, we have the various and sundry things that can happen, like let's take stress fractures.
Okay.
What about them?
Okay, a stress fracture is very common. You got to remember is you're pounding and pounding your feet for a long distance. Okay, so what can happen is, and they used to call these march fractures. They called them march fractures. Men or women would walk in a parade and suddenly start to limp because the bone doesn't break sometimes. It just cracks. Just a little line in the bone. That's why they call it just a stress fracture. Right. It starts to swell. They don't know why it keeps hurting every time they walk on it. And basically, stress fractures will mostly heal themselves, but the problem is you need to stabilize them a little bit. You want a stiff-soled shoe or something so they don't keep breaking. The only time we have to do intervention when it comes to a stress fracture is we have to make sure that it's in position. We want to make sure if you have a weight-bearing bone, if it's lost position in any way, we have to reposition it and then allow it to mend. Now, a stress fracture on an X-ray can be missed because it's such a little line. Yes. So we'll have to wait a few weeks, take another X-ray, and then we'll see something surrounding that bone, which is called bone callus, and it's like a haze.
Right.
Well, you know you have a stress fracture then because you see the haze around that bone.
Exactly.
Yeah.
Now, I happened to, many years ago, I guess about 15 years ago, I was physician at the finish line in the New York City Marathon. And I found that the elite runners were the ones who had most of the stress fractures.
I believe that.
I guess because they're so intense and they're paying no attention to their feet and their lower legs.
That's very true. Second, you got to remember that also the anatomy makes a difference. There are people who are supinators, and that just means in-toeing a little bit.
Right.
The fastest runners are supinators, okay, because their foot almost automatically goes in a position to push off, and they're flying down the most people are pronators. That's out-toeing. And that means you have to bring the foot back up and around. The supinators, the real fast people, they're hitting that ground so hard and so fast. And again, fatigue. That's what most of it is, just fatigue from constant pounding.
Absolutely.
Suddenly the bone cracks.
Incredible.
It reminds me also of ligaments, tendons. They get harder as we get older.
Right.
So naturally, you wonder, why am I getting all these injuries now I never did before? You're getting older. Your tendons are getting harder. Your arteries are getting harder. That's why you have high blood pressure, right? Ligaments get harder, so you rip them easier. You get more ankle sprains than you used to.
Right. And I guess runners, both men and women, have good bone structure.
Yes.
But we're not necessarily assured of that with some runners, because like with everything else, there's an outlier who has maybe some osteopenia, which means a lack of total bone structure. Those of you who get bone mineral densities or bone densities know that osteopenia is not that rare, particularly in postmenopausal women who also run these races. But like take somebody like a male who has a stress fracture. And if the stress fracture occurs at the 15th mile of this 26.2 mile race, they should stop, and they usually do bow out because of the excruciating pain.
I almost think they can't run through it because movement, why do we put a cast on somebody who has a broken bone? We put it on so there's no movement, and then it doesn't hurt. Exactly. You're pounding that foot and it has a stress fracture, you're going to have to stop. It's going to be way too painful.
That's extraordinary. So that's also very good to know. What about ankle sprains?
Okay, ankle sprains. Again, let's go back to the ligaments attachments around the ankle. The most common ankle sprain is on the outside of the ankle. They call it a lateral collateral ligament. Not that you have to know that. And basically what happens is you go over too far, it stretches or hyperextends that tissue, and now, it's painful because you now have injured it. Best advice there, of course, is, the RICE idea, rest, ice, compression, and elevation, because you want to make it solid. Don't take your sneaker off. Leave your sneaker on, wrap it with an ace bandage, put ice on it. You want to take the inflammation out, anti-inflammatory ice, and basically get it down. Then we can luckily go to, these are great new braces that are out there, air casts and so on, which allow you to still do a function and still not re-injure it. Because you don't want to keep re-injuring any kind of ligament. Because if it gets too stretched out and it doesn't heal properly in the right position, it'll be chronic.
Right.
You'll be spraining it all the time.
And they will not be able to continue to run.
No. And these people are fanatical usually. And I want to say this for just casual runners as well as the professional runners.
Yes.
You want to take care of your body. Allow it to mend when it has to so you can continue doing this because you enjoy it.
Right.
If you become too fanatical about it and you injure yourself over and over again, there's going to be a point where you can't enjoy it anymore. Absolutely.
Well, that's terrific advice. Now, at one point, we were aware of something called plantar fasciitis.
Yes.
Is that as common as we think?
It's the most common injury of the foot in this country.
Wow.
Plantar fasciitis. Again, I go back to the idea. We get it more as we get older. It's really, again, ligamentous attachments on the bottom of our foot, okay, on the plantar surface of our foot or the bottom of our foot. There are 3 bellies of these ligamentous fibers. And what happens is they're meant to allow you to hit the ground, stretch, and then snap back again. Well, something happens where you stretch it too far, you get into a hole, something overextends it, and it either pulls, stretches, or rips. If it does that, every morning when you get out of that bed, you can't walk. Because you step down and it's excruciatingly painful, which, by the way, most people come in saying, how come I rested it and it hurts more after I rest it? It's because the ligaments tighten up when you get off of it, so you stayed off of it, but as soon as you bear weight on it, it's pulling it again, and now you're in excruciating pain again.
Wow.
Believe it or not, the pain starts to diminish after you've taken a few steps because you now restretched it. So the idea there is we got to repair it. How do you repair it? Now, like we said, there's injections you can give people. I always mention the PRP, with the
what
platelet.
What is PRP?
It's platelet enriched plasma.
Yes.
And what we're doing is we're taking blood out of somebody, spinning it down to get the nice materials, the clear part of the blood. And in there are all the growth factors and the platelets and so on.
Right.
Now, this was brought over from Europe for soccer. The soccer players, of course, are fanatical. They got to get them back on the field as fast as possible. Ligaments are not fast healers. Ligaments around your ankle, ligaments on the bottom of your foot are all problematic because they're white tissue. Tissue that is white does not get a lot of blood in it.
I see.
Now, muscle got blood galore, so it heals much faster. Bone heals faster than ligaments. So the idea was if I put this stuff around that ligament, will it allow it to heal a lot faster?
And it does it.
It does to a degree. It means I've got to re-injure that ligament because I have to kick the body into gear to think you have re-injured it, and I'm giving it the good stuff to do it. But it takes a good 8 to 10 weeks for a ligament most of the time to repair itself.
So basically a runner, what we're saying here is a runner who gets plantar fasciitis needs some time off.
They do.
Now, it's interesting that you brought up soccer, and I'm sure this occurs in football as well as baseball.
Yes.
Anybody who's using their feet and running, and we hear about players who have injuries to their feet, but they're, the managers are not very specific unless the doctor speaks. So
it almost ended Joe DiMaggio's career. He had plantar fasciitis.
Really?
And there's a misnomer because people hear a heel spur.
Yes.
People will come in and say, what's the difference between that and a heel spur?
Yes.
And basically, the reason you get the heel spur is when the ligament pulls off the calcaneus or the heel bone, the body thinks it has to repair it. So it starts to create more bone off the edge of that bone, trying to gap it together.
Right.
But that spur is not what's causing the pain. That spur really has nothing to do with anything.
Right.
People take an x-ray and they show me the spur. It doesn't matter. Support of that arch will prevent re-injury and allow it to repair itself.
Right. Is there a difference between people who have a normal arch and people who are flat-footed?
I would say there's no question the more flat foot you are, probably the more likely you will get to injure it. But I have a mixture of both because most people don't realize that they go over a curb. Now, when they do it, they never remember that they've even injured it because it doesn't hurt. It's the next day it hurts. And they said, I don't even remember doing anything. I didn't do anything.
Right.
That's usually plantar fasciitis.
Wow. That's phenomenal. Very, very interesting. I mean, I'm learning all of this stuff as a rheumatologist. I know of these
because you don't
diseases.
come across it like I do every day.
No, you come across all of this stuff, and this is so important to people out there who play sports, and particularly the runners that are going to be running various long-distance races, both this next month and thereafter around the world. This is valuable information for everybody because we're all
running
humans.
Is becoming so popular. I mean, it's a workout for most people.
Yes.
So I always say, really, just do it properly so you don't hurt yourself.
Absolutely. What about I had a waitress who came in and said she's on her feet all day, and all of a sudden she gets pain in the back of her foot or leg, and it turns out it was an Achilles tendonitis. And we had also a patient that I saw recently with an Achilles tear. So what exactly happens?
Okay, so what happens is, as I mentioned before, ligamentous tissue and tendon tissue are white. I've done thousands of surgery, and you open up a foot or an ankle, and you can see the difference in tissues. Ligaments are white, tendons are white. They don't get a lot of blood. Easy to injure as we get older. Just like I said, they get harder, so they're easier to injure.
Yes.
Now, an Achilles tendon, believe it or not, is made up of two tendons. Okay, there's two muscles in the back of our lower leg or calf that make up the Achilles tendon. One connects above your knee, one connects in the back of your leg, and basically come down and connect at the back of the heel bone.
Right.
What happens is, in most cases, either people again did an injury, or they had chronic injuries that caused this to rupture. You can get something called a Dell sign. A Dell sign means these two tendons, which are overlapping, pull apart. And if you feel the back of the heel, you'll feel an indentation. It's called a Dell sign. And then we know you've injured your Achilles tendon. I'm very careful with Achilles tendons because we cannot afford to let that rupture, because that is really, then we have to go in and repair it, which I've had to do.
Yes.
On the other hand, what we'll probably do then is we put people in a cam walker or some device so that it rests it gives it a chance to heal. I do not like active stretching until after it's really mended properly, because we want to make sure it's strong before we start getting it looser. If it's chronic, we might even have to lengthen it to make it so that it doesn't keep doing it, because some people have naturally tight Achilles tendons, and women, of course, have it more than men.
Yes.
High heels.
That's exactly right. The high heels.
High
That's a
heel.
famous high heel story.
That's it, high
And for
heels.
all you ladies out there,
Yep.
particularly you
Yep.
long-distance runners who wear high heels, beware. Now, we know the Achilles tendon rupture that really made history was with Aaron Rodgers and the New York Jets.
Yes.
They recently hired, or they did.
I think it
not
was the
recently.
first game.
That's right, the first
First-
game, and there was a big debate about artificial turf and real
Yes,
grass.
yes.
So, how does artificial turf cause an Achilles tendon?
All right, so remember
rupture?
this, our evolution, okay? Our evolution, we were designed to run and do things on soft material, dirt, grass, things of that nature. So there would be a give to it when we hit the ground. When there is no give, it's a sudden and abrupt stop. Okay.
Yes.
Now, in football, of course, I can't. You're getting hit from every direction.
exactly
Somebody's
right.
knocking you over.
Yeah.
Your heel is down, and somebody knocks you over.
Yes.
There's many ways you can injure
We could do
yourself.
several
Yes.
shows on injuries of football
Oh my
players.
God! Alone. Yep, you're right.
Yeah,
You're
that's
right,
great.
100%.
No, really. So this is really amazing. I'm taking in a lot of information. I hope you, our viewers, are learning so much from this particular episode. Morton's neuromas.
Okay, Morton's neuroma. Believe it or not, Dr. Morton described a specific foot type. The specific foot type was the three middle toes, your second, third, and fourth toes, are almost equal in length, okay? And the three metatarsals that are attached to them, which are the bones that come down and attach to your toes, are also similarly, similar in length. The first and the fifth are a little shorter. Okay, so I don't want to complicate matters. In nature, this would never be an issue because you'd be running, your toes would be apart and everything else.
Right.
But shoes and things of that nature want to put pressure on the lateral and medial on the sides of our foot, and that squeezes these bones together, and particularly between the third and fourth metatarsals, the nerve runs in here and innervates or gives feeling to the two toes that it relates to. So the third and fourth toes are the toes that get the Morton's neuroma. It's a bulbous nerve that's been injured multiple times, and it just enlarges. So now you put on a tight shoe and it pinches it.
Yeah.
And now all of a sudden it's burning and tingling and sensitivity in my toes. So I'll try to lift that up a little bit to take the pressure off of it. Again, a corticosteroid injection, anti-inflammatory to help it. Ice would help that.
Do you inject alcohol into them?
I do. Dehydrated alcohol has been a treatment plan for many, many years.
Yeah.
It's effective for some people, but I try to go more conservative if I can and just put elevation with a metatarsal in the right position because it'll take the pressure off that nerve. And as long as it's not getting traumatized, it sometimes won't hurt you anymore.
Right. And in yoga class, those of you who are aficionados of yoga find that when you're barefoot and you're hyper-extending your feet on the yoga mat, if you have a Morton's neuroma, it hurts like the dickens,
Yes.
and you will experience that.
Yes.
And so if your feet or one foot hurts and you have that little mass.
Yeah,
that
and
button.
especially in certain positions when you do things where you're putting pressure on the side of your foot because it's pushing the pressure against that nerve, and that's what sets it off. And once it sets off,
yeah.
neurological things don't just go away.
Right.
They will bother you for a long period of time.
Absolutely. That's incredible. This is a question that I have been asked many times is, should I be on antibiotics? And can these cause tendonitis or rupture my tendons and all that? And I think the patient that asked that question was on a Levaquin.
Again, Levaquin is a known antibiotic that can cause just a rupture of the Achilles tendon. I have used Levaquin many times for different infections, very effective antibiotic, very powerful. But because of that, I use it as a last resort because it is one of the problems. It can just cause a rupture of the Achilles tendon.
There are other antibiotics that also do that.
Yes.
Yes.
Levaquin is the most widely used of all of them. And, even some of the cephalosporins have been said to do that.
Really?
Yes. But, we have to treat infections with antibiotics. Sometimes, you just give people the idea if something, like that could occur. It's rare. I mean, I've only had that happen maybe twice in all my career.
Well, in my business, where we treat a lot of connective tissue and autoimmune disease with hydroxychloroquine and chloroquine, we do see this kind of tendonitis. And I guess it's not tendonitis, but it could be.
It could be, but it usually just snaps.
Just snaps. A rupture.
Now, I'm not sure if that's because it's hardening the tendon in some way, and because of that hardening, there's an easy, it can snap easier. I'm not sure. And they've done thousands of studies on this.
Yes.
But so far, no one's really absolutely sure why it happens.
Wow, that's incredible. It's so interesting and so important. Do you have any final things you'd like to leave with our marathon runners, football players?
One more thing I'd like to bring up is shin splints.
Great idea.
Yeah.
Because, we hear about that all the time.
Now, I mentioned before, we were designed to hit the ground, and the ground should give a little bit. But most of us, and I ran winter track and all kinds of things, we run on pavement, we run on concrete, we run on hard surfaces. Now, the way we run, we hit that ground very hard. We have to decelerate our forward motion. The musculature in our calf is doing most of the work, and it's attached at the front of the bottom of our leg with all this ligamentous tissue. Now, when constant pounding and trying to stop you, this gets all inflamed, and it's called shin splints. It's just the shin bone gets all hot and red and swollen and painful. And the best advice always is rest, of course. Ice it down, anti-inflammatory.
Yes.
You don't want to put it in heat. When I ran, believe it or not, they would put me in hot whirlpools because I was getting shin splints, and that just made it worse because now we're inflaming it.
That's so important to note. So everybody watching, when to use cold and when to use heat.
Ice is an anti-inflammatory. Now, sometimes we'll use both, heat to bring blood to the area and then ice to cool it down because it's inflamed it.
Extraordinary advice. Almost too many facts for one video podcast because this is extraordinary information that is extremely useful to everyone. Now, I'll just ask one last question. Everybody's got their child, their 10-year-old, their 12-year-old in competitive sports, and they're running, they're playing football, baseball. Not many of them are doing long-distance running at that early age. But is there an advice that you can give regarding youngsters versus teenagers versus young adults? I mean, does it make a difference with regard to tendonitis and other things?
And I really don't think so, and I'll tell you why. The younger we are, the less conditions we get like this because we're so flexible, but I do like people to stop getting shoes that are too large for a foot. Movement in a shoe is the worst thing that can happen. And this is one piece of advice I give all day.
Wow.
People think, I'm not going to have any more trouble. I'm just going to get a shoe bigger so I don't have to worry about it.
Yes.
And what they're doing is a shoe is designed to bend right where the ball of your foot is. If you make it too long or too wide and you're moving around in that shoe, that's the worst thing that can happen, especially in a sport because you're stopping and going and everything else. So I say that's my favorite advice. Make sure the shoe fits properly.
Right. Okay. Well, Dr. Jansen, we really want to thank you for this most informative
Thank you for having me.
episode here. And I think that this is going to go far and wide as far as advice to runners and young people playing sports and older people running and doing sports. I mean, we've got people playing pickleball at 80 and playing tennis at 85.
Yes.
And all of these points that Dr. Jansen brings to us are very, very relevant. And I really want to thank you for coming to the show and being on
pleasure,
today.
Bob.
Thank you very much.
Thank you.
Thank you for joining us on Health Frontiers. I hope today's episode provided valuable insights into your well-being. Remember, this podcast is not a substitute for professional medical advice, but a source of knowledge and guidance. If you have any questions or topics you'd like us to cover, please reach out. Make sure to like, subscribe, and visit our website at www.healthfrontierspod.com. Join us next time as we continue our quest to uncover the latest in health and wellness. Stay healthy and empowered. Until next time, I'm Dr. Bob.